Hi, AD. Please take a few minutes to review with me the rapid sequence intubation equipment and medications in our department. I've also included a review on the crash cart. We're going to start with steps to intubation. The first step is to prepare your equipment. You'll need an RSI kit from the Pyxis, saline and sterile water vials, blunt needles, a valve mask or ambu bag, a laryngeal mask airway, intubation tray, laryngoscopy and light sources, gyroscope and bougie, and cardiac monitor, a CO2 detector and monitor, 2 IVs, a suction setup, which now we're keeping in the cabinets, and post-sedation medication. So let's break that down. We want to keep the equipment outside of the room for COVID-19 presumed patients. I suggest you bring things closer to the room so that you're not running around trying to get equipment. You'll want to have the crash cart, the difficult airway cart, and the IV cart handy. You're going to find the laryngoscope and light sources in the crash cart. The options that you'll have are the Max and Millers. You can see that the Max have a slight curve and the Miller is a straight blade. You also want to check the light source is working before it goes into the room. So you would connect the light source to the blade. This is the light source and then the blade. And once you put it in this position, the light should go on. If it doesn't, you can open this bottom portion here and replace the batteries. There's a couple of light sources in each crash cart and in the difficult airway cart should you just need to grab another one quickly. The other thing you will find in the difficult airway cart is a bougie. A bougie is this blue tube here as seen in the picture. This device is inserted into the airway first, and then the endotracheal tube is railroaded over the bougie into the airway, after which the blue part is removed. So this is physician preferences if they want to use the bougie. The Gyroscope can be found in this storage room. It will have a couple of blades in this basket. They're called S1, S2, S3, and S4, and they have their designated weight in kilograms on the packaging. If you need more blades or you need to replace what's in the basket, you can go to the ortho closet, and in these blue baskets you'll find extra blades for the Gyroscope. You'll find a red box with extra bougies. You'll find rigid reusable stylets that you would need for the Gyroscope, and single-use stylets in size small. The other thing you will need is a CO2 detector. This can be found in the airway cart or in the crash cart. They're in both places, or should you need more than one. And you also want to grab the CO2 monitor that is in the storage room. This is a CO2 monitor. It has a 3-hour battery life once it's fully charged, and you could put it right on the stretcher rail or on an IV pole. And then you have this tubing with the yellow is compatible with the ET tube. The orange one is a nasal cannula with the flap over the nose to read the CO2 monitor. Normal CO2 is 35 to 45. That's what you would expect, say, during a moderate sedation. During a code, if you're giving good compressions, you should see a CO2 of about 20. If you get return of systemic circulation, that number will spike very quickly, and it can be a cue for you to check for pulses. The rapid sequence intubation kit is under rapid or ISI in the Pyxis. It's a little box just like shown in the picture here, and it has one pre-drawn acetylcholine syringe that has 200 milligrams, an Etomidate vial with 20 milligrams, and a vecuronium pre-drawn vial with 10 milligrams. Anything that you don't use in the kit, please be sure to send back to the pharmacy so that they can replenish us immediately. The difficult airway cart can be found in pot 2 under the cabinet. The first drawer you will find suction catheters in various sizes. The next drawer has LMAs and extra ET tubes of different sizes. The next drawer has tracheostomy tubes, and you can see that there's an extra light source in here as well. And in the next drawer you'll find a cricothotomy kit. You'll find oral airways, stylets for intubation, and extra CO2 detectors. The next step after gathering your equipment is to pre-oxygenate the patient. The goal is to have an SpO2 as high as you can because the patient will not be oxygenating while they attempt to intubate. A healthy adult will desat in approximately 7 minutes, but a critically ill adult will desat immediately. So you want to try to pre-oxygenate for a few minutes, get the SpO2 as close to 100%, either with a non-rebreather or with an ambu bag would be more effective. The next step is pre-treatment. Fentanyl is commonly used for pre-treatment because it blunts the sympathetic response to intubation. When the tube is introduced, it causes an increased heart rate and increased blood pressure that can lead to MIs, it can lead to ventricular arrhythmias, cerebral hemorrhage, left ventricular failure. So using fentanyl as a pre-treatment can help blunt this sympathetic response. Lidocaine is no longer recommended for pre-treatment. Step 4 is to give the induction agents. So you always want to give the sedative induction agent first. In this case, in our kit, we have 20 milligrams of Etomidate. It is weight-based, so the physician needs to be clear how much you want to start off with. This provides a deep state of unconsciousness and analgesia without causing hemodynamic side effects. So your heart rate and blood pressure should remain the same. Once the sedative goes in, you want to follow that up with the paralytic, always in that order. So you can either give Sux, which your pre-filled vial, you'll find 200 milligrams of Sux. This has a quick onset of 45 to 60 seconds, and it's going to last you about 6 to 10 minutes. The other alternative in the kit is vecuronium. Vecuronium has an onset of 75 to 90 seconds. It's really important that you relay to the physician who's intubating and giving you orders for medications the 3 meds that we quickly have available in our kit. We don't have rocuronium in the ED. This one is mostly used in the OR here at Griffin. So please be sure if they want something else for sedation, such as ketamine or Versed or Propofol, that you're getting that in addition to the kit with the paralyzing agents. So in this chart, I just wanted to quickly show you the duration of the different sedative medication. and the paralytic medication. So you can see that you're talking about Etomidate 3 to 12 minutes, ketamine a little bit longer, 10 to 20 minutes, propofol 5 to 10 minutes, Versed 15 to 30 minutes, and your paralytic about 6 to 10 minutes, which should give you an idea of how long you have before your patient may start to fight the vent or start um, coughing or biting on the tube. You want to get your sedative agent fairly quickly so the patient doesn't get uncomfortable. The next step in intubation is going to be positioning, which the physician will determine what's the best positioning for this patient, putting them in a sniffing position, making sure that the ear is aligned to the sternal notch. You may need to help position the patient, put a pillow under their head, make sure that the height of the bed is appropriate for the person that's intubating. The next step is going to be to intubate. You want to make sure you're keeping track of the size ET tube that is being used. Commonly for adults, we have an ET tube of 6.5 to 8, depending. You might start with one size and find that you need to go up or down on the size. So having a couple different sizes available for the provider is definitely helpful. These smaller sizes for a pediatric patient are going to be found in the Braslow cart. The next step in intubation is going to be checking for placement. The first thing you could do is check for lung sounds. Make sure you have lung sounds in all lung fields and there's a symmetrical rise in the chest. You can use the CO2 detector that will change from purple to gold, indicating that you are in the lungs. You can also at that time hook up your CO2 monitor to keep a continuous reading of the CO2. The ET tube needs to be secured and you want to note what the centimeter marking is at the lip so that if it needs to be adjusted after the chest x-ray is completed, you can tell how much you need to go up or down. The other thing that you want to do before you get that x-ray is to place an orogastric tube. It's very simple to go in through the mouth. The trachea is already occluded so that you're not going into the lungs. It's going to go straight into the esophagus. You want to measure the earlobe to nose to the epigastric area, which should give you a estimate as to how far in the tube you're going to put in, and you're also going to note the centimeter of that tube. And I usually just tape both the ET tube and the orogastric tube together. You want to anticipate for hypotension. This is very common after intubation because of the increased thoracic pressures. It doesn't allow enough blood flow to return, which can decrease cardiac output a bit. So putting fluids, giving a small bolus is usually enough to fix the hypotension. And then, as I mentioned before, you want to get that sedation ready before the patient starts to bite on the tube. The respiratory therapist will make proper adjustments to the vents, but in the case the alarms sound, there are some simple troubleshootings you want to keep in mind. The machines have low pressure alarms and high pressure alarms. For low tidal volume alarms or apnea alarms, you want to check for any disconnection in the circuit. It can also be from inadequate inflation of the tracheostomy tube cuff, which you would need respiratory therapy to help with, or the patient may need higher levels of air than what the vent is putting out. So if you've troubleshooted, you see that everything is connected properly, then definitely want to get respiratory to help. In the event that the machine isn't working, it's not adequate ventilating the patient, the safest thing to do while respiratory gets there is to get the ambu bag, disconnect the mask part of it, and connect the ambu bag directly on the ET tube. You want to remember that for an adult, you want to give a rescue breath every 5 to 6 seconds. If the vents are giving you high pressure alarms, this can be from the patient biting or fighting the vent. The tube may be kinked, which is an easy fix. You just want to make sure that all the tubes are open. The patient may be coughing or having bronchospasms. There also may be an accumulation of water in the circuit because of the humidified feature. Sometimes water starts to pool, in which case you could just disconnect, get the water out, and put it back together. There may also be an obstruction from mucus, so you can try suctioning the patient with the closed suction system of the vent. So important things to include in a report if the patient is going to a higher level care, whether they're being transported out or coming up to the ICU. You want to include the ET tube size and the OG tube size and the centimeter at the lip and the side of the tube on the patient's face. Is it going to the right side or the left side? Because that starts to break down the skin over time. You want to include the x-ray status. You should have a confirmation x-ray ordered and completed, but if not, let them know where we're pending with that. And you also want to include the ventilation settings. The machines can be very fancy and have multiple ventilator settings, but the two most common ones that you'll see is assist control, which is a set amount of breaths that the machine is going to be programmed for, or it can be synchronized with the patient's breath. So if the patient is missed a breath, the machine will breathe for them. You'll also want to include the respiratory rate, the tidal volume, which is the amount of air that is given in each breath. For a smaller person, 400 mLs. For a larger person, about 800 mLs. And then you also want to include the FiO2, how much oxygen the patient requires to maintain appropriate blood oxygen level. We usually start at 100% and then work our way from there once we have ABGs. And then is the PEEP, the amount of pressure that's applied at the end of expiratory phase, which helps keep the alveoli from collapsing and keeps them open so that you can have air exchange. So something in the report should sound something like you have a 7.0 ET tube on the left side of the mouth, 23 at the lip. The OG tube is at 40 centimeters at the lip, confirmed by x-ray. Ventilator settings are AC at 12 breaths per minute, tidal volume 600, FiO2 of 100, and PEEP of 5. The other thing I wanted to quickly review with you was the contents of our crash cart. As mentioned before, we want to keep the crash cart outside of the room as to not contaminate the whole thing, and have somebody handing over the meds and equipment as needed. For a cardiac arrest, the ambu bag, defibrillator pads, and life pack will have to be in the room. So the first drawer is where you have all your medications. Okay, you have adenosine, for SVT, first dose 6, second dose 12. If you need a third dose, you will have to go to the Pyxis to get the other 2 vials. Amiodarone for VTAC with a pulse, along with the filters. You have your 150 milligrams that you're going to give over 10 minutes. And then you also have your amiodarone for cardiac arrest. Remember that the first dose is 300 milligrams, and then the second dose is 150 milligrams for a total of 450 during the cardiac arrest. You also have an anaphylaxis kit, which includes methylprednisone, Benadryl, and epinephrine for IM injection. There's atropine Bristagets, 1 milligram each. You'll find 3 total. The max dose of atropine is 3 milligrams. There are 2 calcium gluconate vials, 1 dextrose amp of 50%, 2 diazepam vials for seizures, 1 dopamine drip for hypotension, and then you have 10 epinephrine syringes. We still have a shortage of the Bristagets, so you will see single 10 ml syringes with 1 milligram of epi. 2 flumazenil vials for benzo overdoses, 3 Keppra vials for seizures, 2 magnesium vials of 1 milligram each, 2 metoprolol, 5 milligrams each to reduce heart rate. You have 2 Narcan 4 milligram vials for opioid overdoses, 2 norepi or levophed vials for mixing a drip for hypotension, and 2 bags of normal saline for making drips. And there's also 2 vasopressins to increase blood pressure, although vasopressin is no longer recommended for ACLS meds. The second drawer, you'll find items to place an IV. There's syringes and needles for drawing up meds. There's flushes, ABG kits. This may run out quickly, so having the IV cart close by is helpful for most of these items. The third drawer, you have your code sheet, although we can document on the electronic cardiac arrest flow sheet as well. There's sterile gloves and a suture kit, an extra tape. The fourth drawer has normal saline and dextrose solutions for your fluid replacement or drips, IV tubing, a dopamine drip for hypotension, and also you'll find McGill forceps that can help guide the ET tube during intubation and can also be used for removal of foreign bodies in the airway. The fifth and bottom drawer, you'll find a whole section set up with the canister and the regulator. You will find that we're keeping our regulators in the cabinets for now so that they're not contaminated with each patient that goes in there. And there's also a triple lumen kit. This may be in the bottom drawer, or depending on the model of the crash car, if it's a newer version, it may be in one of the drawers. There is also a second ambu bag on the bottom drawer. I hope you found this helpful. If you have any suggestions for education review, please let me know. There's a lot of changes that were going to happen day to day as we deal with COVID-19. But for now, I wanted to do this quick review with you so that you can be just a little bit more familiar with what's in the crash cart and your RSI. Stay safe, everybody. Have a great day.